Good morning, good morning, everyone. It is 11:01 a.m. We are so glad to see you here today for our China Chip Learning Collaborative, our amazing second virtual learning collaborative session of the year. Second to last one, we have Dr. Melissa Fair and Pam Gillum with us to talk through leveraging community partnerships for stronger chip outcomes. So we are going to have a great session for you today. We got a lot of stuff to get through, and we're going to let Melissa and Landon take it from here.
All right. Well, good morning, everyone. My name is Landon Campbell, and I am one of the two program managers overseeing the work with the Alliance for a Healthier South Carolina. Thank you all for joining us today for our first chip-focused virtual learning session. I'm joined today by our other program manager, Hannah Ho, Katie Zinger with Zinger Strategies, and our content matter experts, Dr. Melissa Fair and Pam Gillum. So before we dive into our learning session, I'd like to touch on our broader work. So Collective Impact in Action is a multi-component grant initiative funded by the Duke Endowment that focuses on strengthening infrastructure needed to implement public health activities across the state of South Carolina. We have four key strategies to produce coordinated, data-driven action that reduces disparities and advances equitable population health across our state. So the first thing we do is we strengthen data infrastructure. This provides us with the information needed to make informed, evidence-based decisions. We are aligning our community health needs assessment and CHIP processes. This allows us to establish shared priorities and coordinated goals across communities. We train in results-based accountability framework, which creates a common language, a common agenda, and translates plans into actionable strategies and measurable outcomes. And to round us out, we are implementing Clear Impact Scorecard. This allows us to monitor progress of these action plans, increases the transparency of those plans, and also drives continuous improvement. So with that, I'd like to get us started with our content for the day. I'd like to turn it over to Dr. Melissa Fair and Pam Gillum to introduce themselves and take it from here.
Welcome, everyone. As Landon said, I'm Melissa Fair from Furman University's Institute for the Advancement of Community Health. I'm co-leading the webinar today with my colleague Pam Gillum, who I will turn it over to introduce herself and get us started with an icebreaker.
Thanks, Melissa. Good morning, everyone. Good to see your faces. I'm Pam Gillum. I'm the director of the Center for Applied Research and Evaluation in the Arnold School of Public Health at the University of South Carolina. And we're excited that y'all are here today to talk with us about engaging the community in the community health improvement planning and implementation process. So I want to have a fun icebreaker for us real quick. The reason why we picked this exercise is this is something you could do back at home with your community. It just gives you one more thing to put in your toolbox. But we know that in community engagement, trust is the foundation of collaboration. And so I thought we would today talk about building trust. And so we're going to talk about building trust in the context of a checking account. So I don't know about you, but I love deposits into my checking account, right? I like way more deposits than I like withdrawals. So when we think about deposits that build trust, what does that look like in terms of engaging the community? So when you think about partnerships, collaborations that you're involved in, what are those deposits, those behaviors that generate trust? So if you'll open up your chat box, think about what is it that builds trust when you're working with partners? And I'll monitor the chat box. So working hands-on with actual community members. Exactly. Authenticity, reliability, including the community, transparency and communication. Decisions about decisions, and that it's communicated to all partners. Transparency over and over again. Follow through. Yes, follow through. Long-term deposits, bi-directional support. Excellent. Excellent. Love it. Empathy. Great. That's really great. Those are definitely the deposits. Consistency. I see that, Takita. Yes. Okay. So now let's think about these are all the things that generate trust, right? And you can even think about like some of the things that I think about related to like meetings. What is it that's important, like compromise when we're engaging with one another, accountability, all of those things generate trust. They create deposits and help our checking account overflow. Now, let's talk about it from the opposite. What are those withdrawals that creates distrust? So, what does that look like in terms of working with partners in your community? What generates distrust? Lack of communication. Side meetings, yes, Melissa. Exclusion, right? Dishonesty. Hidden agendas, right? Not following through, not sharing power. Excellent. Silos, right? Silos can create a challenge. It makes it difficult in terms of collaboration. Great. Lack of inclusion. Excellent. Yeah, Casey. So again, when you think about this, and I actually do this exercise with my students in a leadership course that I do in the fall every year, we talk about this. We talk about the importance of trust in collaboration. And these are the behaviors that you've shared that really creates trust and helps build trust within collaborations, and then those behaviors that generate distrust. So nice. I hope that gets you primed a little bit as part of this conversation today, because really today we're focused on like what is the structure that looks like that could be how you could increase how you engage communities over time as part of the community health improvement planning process. And so I'm going to hand it over to Melissa, who's going to build upon our icebreaker today in terms of how to build trust.
Thanks, Pam. So before we get started, I'm going to quickly recap what we're going to talk about today. So as Pam mentioned earlier, this webinar is really about the implementation process. So your community health improvement plan. We've talked a lot in previous webinars, if you were able to join us, about the CHNA process. So today we're going to focus on engaging community in the CHIP process, potential governance structure, so ways to support transparency, communication, decision making, and then talk a little bit about how aligning community and hospital priorities can do things like strengthen partner engagement and build trust over time. So why do we engage community? One of big reason is to create shared ownership. We know that health systems cannot solve every health problem within the clinical walls of the health system. Also, when you look at the IRS regulations around CHNAs and CHIPs, hospitals are required to create a plan, not be the sole owner of the process of improvement. So that can also live with community partners. We know that there's some good evidence out there that it actually increases the effectiveness, especially when we're talking about those complex issues like transportation, housing insecurity, food insecurity that really require community-based expertise and resources to make those changes happen. So how can health system partners support those community partners in implementing those issues? Another is it creates shared expense. And we don't just mean financial dollars. It can also be human capital, and so time, expertise of community members or people who work at nonprofits and CBOs. It can be things like space for meetings, co-writing grants together, marketing and communication support, co-location of clinical services in community-based settings. So what a theme you're going to see throughout today's webinar is going to be this level of engagement and this continuum that you see here on the screen. So this continuum moves from left to right. You can see that the degree of difficulty of the work increases as we go up the continuum, but so does your potential for public impact. And as we move up the continuum, there is more and more community engagement and community ownership of the work. One of the things I want to stress as we walk through what each of these models mean is that it does not mean that your goal 100% of the time needs to be to getting to the space of being community led. What we are stressing here is intentionality when you set out to do the work that you're doing, that you have a end goal in mind, and that end goal in mind aligns with the work that you're wanting to do and the level of engagement and involvement you want your community partners to have. So for some organizations, that may be getting to involve or collaborate and saying right now is not the time, or, maybe it's a very clinically based strategy. So the community shouldn't be responsible for leading it. Also, one thing to point out as we move through this, your CHNA and your CHIP may have different levels of community engagement, and that's totally okay. So just being mindful of that and intentional about it is the main goal. So first, we're going to talk about inform. The hallmark of inform is that information is unidirectional and it is flowing out. So this looks like the health system providing information about their findings and what they're doing, but they're not necessarily consulting with the community partners and community members to bring that information back in. Decision making lives with Best Darn Hospital, and big county coalition may just be informed in the process. If you've been with us on previous webinars, you're going to hear us keep referring to Big Old County Coalition and Best Darn Hospital as our two core partners in this work. So BDH, Best Darn Hospital, BCC, Big Old County Coalition. So an example of what information sharing or informing looks like with a community would be that Best Darn Hospital presents the CHIP and provides periodic updates at Big Old County Coalition meetings. So it's a predictable and accessible channel for the health system to share information to the community partners. It's really about awareness building in the community, not necessarily community informing the work. So there's an opportunity to track progress, but all of that decision making lives with Best Darn Hospital. So consult. Consult is kind of the opposite of inform, but the sharing of information is still unidirectional. Community are acting as consultants in the process where we might be asking about their opinions or their experiences, but the health system may not use that information to actually change things. The hospital system still has decision-making power and whether or not and how that input is being used. The process for consulting may be formal and recurrent. And one thing I want to stress here is we're not just talking about data collection, especially because today's webinar is about the CHIP. So in the context of the CHIP, if the only place that you are consulting with the community in the process of your CHNA and your CHIP is through doing focus groups or surveys, you are not actually consulting with community in your CHIP process. So the other hallmark here of power is it is indirect. So community has no direct decision-making power about what CHIP strategies are selected or how they're implemented. So what might this look like? And an example is a series of community listening sessions where we're consulting with community partners. So Best Darn Hospital is getting their input through a formal channel. They're receiving that information and maybe using it to optimize the strategies that they're picking. And they might do it in a number of varied community spaces to try and increase engagement and representation. But that input may or may not actually influence the CHIP planning process, and the health system gets to decide entirely which input matters to them and what they want to do with it. Involve. This is where we start to see bi-directional sharing of information. And the Big Old County Coalition is starting to be an active collaborator or partner in the process throughout the CHIP process. We're starting to see semi-formal structures for engagement, and we'll talk about governance structures later in today's webinar, such as ongoing working groups or committees. Community are helping you identify the solutions to those strategies that you identify, to the prioritization of health issues. So they're actively helping pick solutions and strategies. The community, however, is still playing a supporting role, and the Best Darn Hospital is still owning the majority of the implementation process. Best Darn Hospital has final decision-making authority, controls timeline, resources, etc. And your Big Old County Coalition is playing a supporting role. So what might involve look like? This could be community and review and feedback on data to develop CHIP strategies. So maybe a data working group. So Best Darn Hospital presents the prioritization data to the community. They help them think through and contextualize the results, considering their community knowledge. They're providing feedback about what interventions and strategies would be most helpful and meaningful with the community. Best Darn Hospital is routinely checking back in with that data work group after they've selected their implementation strategies and the work begins to happen. And this is where we see that the Big Old County Coalition might start to play a small role in implementation. For example, if there is a diabetes prevention program that is happening, we might start leveraging the community to help advertise through their communication channels. Maybe they even provide a community center to be a location, but they're not delivering the actual intervention or running the program or doing the day-to-day work. So next is collaborate. This is where power and decision-making are equally shared between Best Darn Hospital and community. There are processes in place where joint approval is required between Best Darn Hospital and Big Old County Coalition for strategy selection, for how that work is implemented, for allocation of resources, for problem solving. So when we make decisions about how to pivot or how we're going to track progress or what success means, the community are not serving in an advisory only capacity. That's going to look more like the consult and involve. So Big Old County Coalitions have an equal say. So Best Darn Hospital might have a voting stake when we go to say which interventions are we selecting, but they don't have the power to reject what the collective decides upon. Big Old County Coalition members and community stakeholders are playing an active role in owning portions of the implementation strategy here. What that might look like is Best Darn Hospital has developed a steering committee that co-designs and implements initiatives and interventions. That steering committee includes CBOs and community stakeholders. It might involve people with community voice. And one important distinction here, when you hear us talk about CBO stakeholders versus community voice is the people who are most directly impacted by the issues we're solving. Community-based organization employees may have lived experience and be part of community voice, but they also may not. And so sometimes we have to make an active effort to include the people living in neighborhoods who don't work for CBOs who have lived experience with the issues. So Best Darn Hospital is sharing decision-making with the committee members. There are formal processes for voting, such as consensus, majority. The Best Darn Hospital team members identify the CHIP initiatives and interventions. And in this process, the Best Darn Hospital is acting as the facilitator and the convener of the community partners, but it's a shared process. So lastly, community-led. This is where community defines the problems, identifies the solutions, and holds the power. This may not always be appropriate. And an example where I gave you that earlier is if it is a clinical issue, we should not ask community to be the driver of the solution, and or if there are no resources to support community in implementing the work. And resources may include financial resources, but it also may be training, capacity building, and other in-kind resources that support community in doing the work. The health system is only providing a supporting and facilitation role, and the community has final say over priorities and action strategies. So community is also the primary lead on implementation, even if the health system may lead certain strategies. What might this look like? It could be a community coalition with lived experience as the decision-making body for the CHNA and CHIP. It's a community-owned board with CBO reps, community members. Best Darn Hospital is facilitating the group meeting. The entire coalition votes to determine the strategies. The coalition decides how success is measured. Stipends are provided for community members participating, and they are the ones that provide accountability and tracking, not the health system. Another strategy for community-led could be a community mini grant program where the coalition is the decision maker of what does the request for proposals look like? How do they score the applications? Who gets awarded the money? How will they create accountability for the community partners? And community members are provided stipends for sitting on that committee that administers the mini grant program. So quickly, I want you to think about, are you ready to do this work? What might be some of the things that we should think about? And that is trust in relationships with community doing community engaged work. Do you have the knowledge and expertise? And do you have the capacity? So what might potential governance structures look like? And what are the things that we should be thinking about when we do this work? So components might include shared mission, vision, values, and strategic goals. So establishing those together, making sure that you have clearly defined what roles the stakeholders have, especially amongst hospital system and community partners. There should be role definition, expectation setting. We should have cross-sector membership. There should be there might be requirements for who is represented from the community. So does the group look like the community that it's representing? Are there multiple sectors at the table? It should consider information flow from and to community, so that bi-directional flow of information. So define channels and clear guidelines around what types of information are supposed to be shared with who and how we're going to disseminate information. So there should be a defined decision-making process, and those rights should be defined. So is it a majority vote? Is it consensus? Do we have to have a quorum established every time the group gets together when making decisions? Can community partners cast votes in the process, or are they advisory only? Other things to consider would be things like meeting logistics. So are the location, the format, the time that the meeting is held, is that accessible to community partners? What about meeting frequency? Are we asking too much of our community partners? Are we not meeting with them enough? How are we disseminating information about the decisions made and the follow-up that happens as a result of those meetings? So accountability and oversight, this is a really important one. We find that one of the challenges that collaborative organizations or groups sometimes experience is they don't have a plan for conflict resolution or grievance procedures when there is not consensus amongst the group. So being upfront about that, how is that going to be handled? You know, who is the designated entity? Is it co-chairs on your steering committee, etc.? Having conversations about what communication and transparency mean to you and the group that is making decisions. So that creates a foundation for trust and relationship building from the outset. But it's also incredibly important when we set those ground rules that we follow through on those ground rules. We heard that that was one factor that was really important for those deposits in our icebreaker is follow through. So creating shared rules of engagement. So how do we want to show up to the meetings? If it's a virtual meeting, do we want to try and have our cameras on? If it's an in-person meeting, do we want to try and avoid screens? You know, are there limitations about how much people should speak or creating spaces for everyone to share their opinion? And then we also have monitoring, evaluation, and adaptation. It is really helpful to have procedures and for tracking progress. This allows for us to correct course when things aren't going the way that we want to, or also allows us to adapt when emerging situations happen. In recent years, we've seen things like natural disasters, changes in funding environments really shape what we are able to do in community, and having a process in place for how we adapt and tracking progress to inform those adaptations are really important. So you should also have a formal plan and process for how often will you review your implementation strategies and progress towards them. You don't want that to be a plan where you're reviewing it so often that you're not seeing measurable progress in between the actual check-ins, but you also don't want it to go so long that maybe you've missed out on the opportunity for course correction when things aren't going the way that you wanted it to. So an example of a governance strategy that you could adopt, and this is not the only one, but it is a good example, is establishing a common charter or memorandum of understanding if one of the things that you've done is develop a coalition or a steering committee for your CHIP. So what would this look like? And so the purpose is to oversee the development and implementation of the CHIP. So that is what the Common Charter would set out to say. This is how we're going to do this. It would define who has authority. So it would state, how are we sharing that authority and decision making between Best Darn Hospital and Big Old County Coalition? So think back to your continuum of engagement, and you would really define, is it bidirectional? Is it equal power sharing? You might define what membership looks like. So what sectors need to be at the table? Do you need direct community representatives? So public health, schools, faith groups, etc. Once you have decided who gets to make what decisions, you're going to set out how do they make decisions? So an example there is consensus building or a majority vote. How many work groups do you have? What do they look like? What are they working on? Who is leading them? You know, do you have co-chairs? Who is facilitating them? And it might also define your reporting process. So between all members of the steering committee or coalition, what is the health system expected to report? What are your community partners expected to report? So some practical takeaways from this work is it always works best when we leverage existing partnerships and community assets to avoid duplication of efforts. So in this example, if the health system says, man, we really would love to have a community coalition guiding the work that we do. In our example, Best Darn Hospital should not go out and create a separate community coalition to monitor this work when they already have big old county coalition at the table and saying they're willing to support and help do the work? Community members, and when we say community members, we mean people who are not showing up compensated by their organization to have a seat at the table in the coalition. So oftentimes, if we're CBO or nonprofit employees, our organizations might be willing for us to come to the table and be paid to do that work. But if you are a community member and you are just a volunteer, you're not going to get compensated. And it might not be fair to ask you to show up and contribute equally. So we might need to develop a plan for compensation. Clarity and transparency are key, and follow through with clarity and transparency are incredibly important. But we also know that we have to stay flexible. And so we have talked about a lot of rules and ground rules and expectations that we want you to set out to create trust, transparency, and formal structures. But we do also need to be flexible and recognize that sometimes what we think might work the best, when we actually go to implement it and do it in real time and real life, doesn't work. And so being transparent and communicative about when we need to make those changes and making those decisions together. As I mentioned earlier, logistics are key. So meeting location, meeting time, meeting format. So aligning priorities is our last topic before we're going to move into an activity. So why are aligning health system and community priorities important? It builds trust with community. We've talked about that it can improve outcomes at the community level and increase buy-in. So we know that community members might be more likely to participate in interventions and initiatives that are driven by community input and community have ownership over. It promotes sustainable impact. So when CBOs and the health system are bought in, the work is more likely to continue even if a grant ends. So it also increases efficiency by aligning the types of resources we talked about early. So what are some strategies for priority alignment? So meaningfully integrate community voice. And remember, when we talked about community voice, we're talking about the people who are experiencing the problem today. So if we are addressing food insecurity, it's people who might be navigating things like signing up for SNAP or WIC, or who might be potential participants for a produce prescription program to support fresh fruits and vegetables for low-income families. Asking the individuals and the families who might navigate those actual systems and programs, what are your barriers? What are your experiences? How can we make this better? Creating a community and health system shared process with those established governance structures. And if you are going to do a shared process, I often suggest using some type of framework to guide your collaboration. An excellent example of a framework that you can use is collective impact framework and its principles. And we'll talk a little bit about that next. Align your goals, metrics, and reporting cycles between the health system and the community partners, and monitor and adapt your CHIP together. And so one thing I always encourage is, if you have an action plan, at any time that coalition meets, that action plan should be your guiding framework for what you're talking about. It should be your framework for updates, for problem solving, for thinking about, do we take this work on or this opportunity on? Does it align with our action plan or does it not? So constantly revisiting that plan and revisiting your tracking and metrics on a fixed cycle. So that might be quarterly, it might be twice a year, it might even be once a year, depending on the type of interventions you've adapted. And continuous transparent communication. So quickly, collective impact. What are the key principles? common agenda, shared measurement, mutually reinforcing activities, and continuous communication. In this instance, your health system may act as your backbone organization, could be your local health department, or it could be the coalition itself that you have decided is the backbone organization. Why is that important? So provides clarity on who's leading it versus what community partners lead, which enhances trust and relationships. So how might you maintain continuous communication? Quarterly meetings, shared data dashboards. We talked about clear impact at the very beginning. That's an example of that work. Progress reports that are made public, cross-sector work groups. So now we are going to move into, as promised, an actual activity that we are going to break out into groups and do. So as part of this activity, we are going to work through, just as a reminder, different levels of engagement. So each group will design a governance structure for a hypothetical community health improvement plan in Big Old County. The two partners in this scenario are Best Darn Hospital and Big Old County Coalition. The coalition is eager to participate and leverage their connections. Each breakout room is going to work on a different level of community engagement, and your task will be to develop a strategy for either inform the community, consult the community, collaborate with the community, or lead the community. We have left out involve because involve and collaborate have a lot of overlap between the two. Your job here is to build a governance structure that reflects your level of engagement. You're going to have a facilitator in the room that is going to walk you through that. So do not worry about having to remember all the things that we talked about earlier. So governance structure aspects are going to be identification of stakeholders, how information is received from community, how it flows to community, what are decision-making processes, and what do meeting logistics look like. And so now I believe Katie is going to send us into some breakout rooms that you're going to be randomly assigned to, and you will meet your room facilitator there.
Yep, give me just a second. And you'll be asked, you click to join your room. Come on. All right. Where do we add these friends? Melissa, assigned to 4. Pam, oh, no. Pam, assigned to 3. Okay. Welcome back, everybody. I hope you had great conversations in your breakout rooms. This is kind of a little bit granular, but also really important to understand the differences and the relationships in order to have these really great community relationships to have better chips. So I'm going to be quiet and let Pam and Melissa and Landon and Hannah do their report outs or their groups report outs, whoever wants to do that.
Okay, welcome everyone. So I will go ahead and share ours. We didn't fill out our template, but I can briefly report out about it. So this group was community led. And so as we talked about earlier, the entire hallmark of community led is that the majority of the decisions live with community in the process. But what we did decide is because the health system has a lot of infrastructure and resources, that they will act as the financial and fiscal backbone for the coalition, but the coalition has a governance structure and rules and charter that are separate from the health system. And what's going to be really important there is the health system can never have a majority membership. And so there's going to be limits on how many members of the voting coalition the health system can be comprised of. We talked about that there would be representation from CBOs from every single sector group that works in the CHIP priorities. Information flow to and from community. So obviously information is going to be shared in community meetings. Each organization is going to report out their relevant information, including the health system, and get shared feedback. But we also thought it was important to have external opportunities for broader community involvement, where the coalition is sharing out progress, getting feedback from the community through things like town halls. There would be also, we would be sharing information with government decision makers, so local elected officials, state representatives, other people in power who have decisions around how funding will be allocated to create transparency, accountability, and share success. We'll have an annual luncheon. Decision-making rights is the community has the ultimate say. We're going to have a 75% majority vote rules, but we will always work to build group consensus to ensure that we have transparency in place. We will have a corrective action plan that outlines a grievance process and steps for how we can course correct to ensure things like the health system not overstepping their role, since they're serving as the backbone organization, and the executive team of the coalition would oversee that process. We didn't quite get to all of the things about logistics, but we got to quarterly groups will meet periodically. The larger coalition will meet quarterly, with smaller groups tackling specific initiatives meeting periodically. So what I now want to ask the group is, do you have any feedback about this structure? Maybe what are some things that you liked about what this group pulled together? And then maybe what is some feedback that you have for us about things that could be done better? And you can put it in the chat, or you can unmute yourself.
I thought you said you didn't take notes, girl. This is a lot of notes.
Oh, I meant in the report out form.
Melissa, I would be interested in hearing your perspective on, like, how do you get the hospital essentially to agree to share this power, and thinking about, like, I think what happens is, like, we have all these things set in place, but then the hospital's like, well, at the end of the day, like, this is on our backs and it's our money that's like funding this. And so how do you kind of like navigate that?
One model that I know that works, and they're doing some restructuring in the Low Country because the United Way, because of the priority area that they're moving into, can no longer act as the backbone. But the Tri-County Coalition down in the Low Country, they do it in two ways. So Roper St. Francis is currently acting as the convening body of that coalition. And Roper St. Francis has an internal chip in CHNA that kind of meets the basic requirements of their IRS reporting, to kind of check the box, and is really focused on internal clinical strategies and QI work. And then there is a community-owned chip that uses those same priorities, or a portion of those priorities, and CHNA data that is collected collaboratively across organizations to have a broader community group that pulls together multiple health systems, CBO partners, academic partners, and there is a community-owned strategy. And so in that situation, Roper St. Francis does not decide what is in the community chip, nor does any one individual health system. And so because their internal needs have been met, there really is no hidden agenda and needing to control that community-based strategy. And the health systems really can just let the community and the process that's been set up by the coalition drive that action. And that has been largely successful for that group in the Low Country. So I guess we will transition to the next group. So Pam, do you want to share your screen and either report
Sure.
out or announce who's going to do your reporting for you?
So Wynn hopefully is going to be able to do it. She's waiting on her IT guy to come, but like if she's here, Wynn, if you want to share what we talked about, and I'll just tell me when you want me to scroll up and down.
Okay, so we were talking about the collaboration section. So first we were just identifying who needs to be a part of that conversation. And without reading through every single thing, like y'all said previously in your group, it would be somebody that is in the field of all those 5 identified priorities. So you have a dietitian, your mental health organizations, reaching out to schools, free clinics. They can identify people who are in the uninsured population. You would also bring in those constituents, that are patients of mental health or are trying to get or have received affordable housing, just to try to get a good, well-rounded group of individuals that can help identify all those challenges, what needs to be implemented to make it better. Talked about the hospital being able to give you some of the data to identify some of those issues, and they'd be able to host meetings in their bigger facilities and could provide medical assistance. Let me go to the next one. Just talking about the information flow from community, how we would get that. That would be surveys, social media. You could reach out to local churches. People trust their pastors and their church community. Sometimes that can be a barrier, is trusting the people who are involved. Making sure we set up meetings in communities that people can get to, that becoming a part of that voice there's no barriers to that, that you're just trying to reach out to as many people as possible in as many medias as possible. And then for flow to the community, we're going to tell them about it in newsletters, social platforms, go to events, set up tables, hand out flyers, try to engage people in conversation, so that everyone's aware of what is happening in their community. We can figure out, if challenges arise. We talked about reaching out to the community for any help or assistance. They could help as things are being implemented. If it was a way we could make them a part of that. We talked about newly identified gap with stakeholders and then reaching out to them to come to the table. And then for the decision-making processes, we just had said that it was equal, but may have to make a decision upfront about authority. So we didn't go into many details about that. And then for the meeting logistics, it might depend on the phase, whether it should be more meetings in the beginning and maybe that's only quarterly down the road. We give updates and offer Q&As, so constituents can share their concerns and tasks can be assigned. And then we want to make those meeting places convenient and easily accessible transportation. Most organizations know transportation is a barrier to a lot of our clients. So you don't want to leave certain groups out or populations in geographic areas because they can't get there to be a part of it. Do you want me to do the report out too?
Yeah, do it. Just talk about one strength, one challenge, and then the question.
Okay. A strength was being able to hear from so many voices and so many demographics, so many constituents, which opposite of that, a challenge sometimes is not getting a diverse enough group. Maybe enough groups haven't been included or hesitant to engage. So that can be both a strength and a challenge. And then one of the questions we had regarding implementing it is who makes the final decision. So if there's big conflicting ideas or opinions between the hospital and the coalition, who gets to make have that final say so.
Great. Thanks, Wynn. I appreciate you doing that.
No problem.
Anybody have any thoughts or reflections on the level of engagement, collaboration, and what it might look like? These were our brainstormed ideas. You're on mute, Melissa.
I think the question y'all asked about, like, given that this is equal decision making and sharing, what happens when there just is an impasse? It's a
Yeah.
really important question, and I don't know that there's any one way to do it, but it should be written into your organizational bylaws. Like, at some point, does the health system, are they the tiebreaker? Does the executive team, which is your, chair, co-chair, treasurer, et cetera, do they make a final decision and they break the impasse? Just writing, does the community organization lead make the final decision? Neither are necessarily right or wrong. I think you agree to what your community agrees to and you write it into your bylaws.
Yeah.
It's my
It's those
perspective.
completely agree, Melissa. It's like those conversations up front about like the decision-making process is so important. We didn't really get a chance to really talk about decision-making process in our group. So, all right, I'm going to pass it on to Hannah. Hannah, you are doing Inform. I'll stop sharing.
All right. Oh wait, I had consult. So my group
Oh,
was consult. They wanted me to do the report out, so here I am. We'll ask for community input. So just some overall notes is that for our stakeholders, identification and roles, we're going to start with the partner list that was listed on the CHNA. So we'll start building kind of a team from those partners that were engaged with the China to increase partnerships for the chip. We are going to work with the Big O County Coalition. We are going to offer like resource list to our partners. And then the hospital is the, final holder of decision making, but we are going to use these times to share what our implementation strategies will be with our partners for feedback in two different spaces. So information flow, we're going to, of course, present at the coalition meetings. We're going to do data walks and listening sessions. But we actually kind of figured it out that at the end, that we're essentially going to have two groups. So we're going to have our internal hospital team. That's kind of the ones leading, driving, and doing the work. And then we have kind of our stakeholder group that's the coalition and any other partners that we needed to have the table that we will meet quarterly with and really just give updates. And then we'll have one in-person meeting a year to give updates and let them provide feedback and give, progress. But ultimately, what those meetings will be a sharing of information that we then take back to our internal team for synthesizing, processing, and decision making. So for our report out, I kind of described our structure. One strength of the model is that the decision-making power is internal, just for quickness. So you're not waiting around for any outside direction. Even though that's less ideal, it is easier to keep things moving forward when you're, carrying the brunt of that decision-making and whatnot yourself. One challenge of the model is that it's obviously short-sighted, and it will be heavily reliant on the goals and objectives of the hospital. And the true intention, if the true intention is to support the community at large, this model has a large chance of missing the mark for that. And then one question we still had about implementing in Big O County is understanding the order of which things should be implemented, and if there even needs to be an order, so what that would look like. Questions?
I'll make a comment. That's a great question, in terms of like order. And I think we get hung up on that. And sometimes it's, do we do low hanging fruit first? Like, are there things that we can be doing, that we know we can make progress on versus others that might be more challenging? Like, those are, again, those upfront conversations. So I love that question.
All right. Well, if there are no other questions, I mean, one thing my group talked about is like this might not be the most ideal way to do it, but it might be the fastest way to do it.
Hannah, one thing that your group pointed out that I think is thematically something we're going to see is at times your strengths, its foil is your weakness. So,
Sure. Yeah. 100%.
that fact that internal processes it does make things are streamlined, they can move a little bit quicker. It sometimes means action can feel faster, but then you pointed out that foil that it means that you might miss something. There might be context or opportunity that's lost because the health system goals are driving that action. So I liked that. So Landon.
All right. Well, I will round us out. So we are the informed group while I am pulling up my whiteboard. Here we go. Hopefully everybody can see that now. So just as a quick reminder, we are focused on that one-way communication, transparency, and efficiency. So just the communications going outward. So as far as, our stakeholders are concerned, in addition to Best Darn Hospital and Big Old County Coalition, we also have organizations such as SC Thrive and the Community Foundation. So Coastal Community Foundation in this specific example. And their job is really going to be to work with those nonprofits that have access to local networks. So not necessarily direct information sharing with constituents within our target area, but one step up with also involving the local nonprofits to make sure that we're hitting all of those gaps in niche areas that you might hit or might miss otherwise. We also want to make sure that we have healthcare providers within the area to directly disseminate that to their patients. So those within Best Darn Hospital, making sure they have that same verbiage and messaging to make sure that that's equitable there. And then to kind of round us out, we want to make sure that we have our community health workers and our local DPH engagement teams involved with direct conversations with our community members. So it kind of rounds out, our big chunks of our stakeholders with our community councils being a little bit of that steering committee in addition to our coalition. Now with that, I'm going to go ahead and move us down into our report out. So just to briefly describe our governance structure, we're going to have those partners from DPH or our government. We're going to have our partners from CHWs and our local authorities, including those county councils, and then SC Thrive at the table to make sure that we're covering all of our bases and making sure that, any of our rural populations, they don't get missed. And then we want to make sure that we're sharing our information in several different formats. So that includes emails and social media that might be more towards our nonprofit organizations or more towards our entities in the communities, more so than our individuals. And then we also want to share it through word of mouth to our community members. And that might be our community health workers while they're on the job. That might be those in our hospital systems. And it might also be our engagement staff at DPH that's really getting into the community, into those niche areas, and making sure that the messaging about our priority areas is shared equitably across the board. Now, as far as one strength of the model, we designated the steering committee as a kind of our backbone structure. So we do want to have a conglomerate or a group of people from our stakeholders instead of one stakeholder organization being that steering committee for everybody. So that we have a little bit more of a broad understanding as to how we need to implement it within our specific target population. As far as our challenges are concerned on the other end, meeting people where they are in rural areas, I'm sure that the vast majority of the people on this call understand how hard that is to actually really reach those niche populations, but making sure that we have the right people speaking within different areas of the community. So those local community champions that we can identify through our local partnerships and making sure that we associate them with their specific area correctly is going to be a big challenge, but also a key component of our governance structure, at least for the informed piece of this. Now, the one question that we had was, we understand like a little bit of the background contextual information as we came to these CHIP priority conclusions and, our priority areas based off of some pre-work. And we're assuming that we involved our communities within that process as we've started this piece. But did those community members actually have a say, not just in the priority rankings, but also specifically defining aspects within these priority areas to really focus in on? So did we actually really focus in on keeping them involved throughout the entire process?
Thank you, Landon. I know sometimes that's a hard one, especially because most of us want to do more than just inform our community. So it can almost be the hardest to like hold yourself back and think about what that could look like. Does anybody have any input about their question before we wrap up? Okay, well, I am going to share my screen again and turn it back over to my colleague, Katie Zinger, to head us out.
Great. Thank you, Melissa. Y'all, that was really, and it's like complicated stuff. And I'm so glad that for your attention today. Really great work in the breakouts. We really appreciate you being there. Speaking of, we have one final virtual session. It's on June 23rd, same time, 11 a.m. to 12:30 p.m. And we really hope you can make it. So you can sign up for that using the same add event function by taking your phone and doing the QR code. It should be able to sign you up there. And then I think Carla's helping me put a link in the chat and you can sign up for it that way. And then of course, in the follow-up emails and everything, we will also have this information. So we really appreciate your attendance and your attention, and we hope you come to our final one in June. It's going to be on from plan to progress, monitoring and communicating community health improvement. So again, around CHIPS and how do you communicate that to your community in a way that's impactful. And then we have, of course, the evaluation. That would be the next slide. Which is the meeting feedback. So again, you have a QR code. You can complete it on your phone. It takes less than 3 minutes if you do it quickly. There's also a link in the chat. Please take a few seconds to let us know what you thought and what we can do better. We've got one final chance to take that feedback and make sure we put it all together for you guys. So thank you so much for your time and attention today. And that's all I have. I hope everyone has a great day. Landon, is there anything else we need to announce from the Alliance before we are finished and we can say thank you to Pam and Melissa?
I definitely just want to say thank you to everybody that joined us today, including Pam and Melissa. And it's just a quick follow-up. We will be sharing a little bit of additional information regarding some additional CIA opportunities that we have, some of our other work, as well as some other opportunities to engage with the Alliance as a whole with our follow-up information. But thank you all again today.